welcome you to our May 11th edition of our Cornerstone Speaker Series. My name is Ken Kahn. I am the Dean of the Monte Ahuja College of Business here at Cleveland State University, and it's my pleasure to welcome you and thank you for joining us today. This series that we call our Cornerstone Series, exemplifies the vision of the Monte Ahuja College of Business to be the cornerstone for Northeast Ohio by creating and advancing business-ready talent, impactful business knowledge, and foundational community engagement. And this speaker series that we have been offering this semester and plan to continue to offer next year is very much an illustration of what we mean by foundational community engagement. Today is the part three of our three-part series, which we have entitled The Other Side of the Pandemic, Our New Normal. Today's topic is resilience and leading through crisis, the Cleveland Clinic experience. We have two speakers today. One of our speakers is Dr. Tracy Porter, who is an associate professor in the Department of Management here at Cleveland State University's Monte Ahuja College of Business. Dr. Porter is an expert on organizational change and organizational success in healthcare organizations. She serves as a lead faculty in our healthcare management program. Also joining us is Dr. James Stoller, who is a pulmonary physician at the Cleveland Clinic, where he serves as professor and chairman of the Education Institute. He holds the Jean Wall Bennett Professorship of Emphysema Research and the Sampson Global Leadership Academy Endowed Chair of the Cleveland Clinic, at the Cleveland Clinic. He is also co-author of the 2018 book, which is titled Exemption to the Rule, The Surprising Science of Character-Based Culture, Engagement, and Performance. Let me welcome and thank both of our speakers today. Thank you for joining us. And with that, I'm going to turn it over to Dr. Porter.
All right. Thank you, Dr. Kahn. Give me a moment, please. I'm going to go ahead and share my screen. What I would like to share with you all is a little bit of research that I recently did. We all experienced a rough year last year where, the pandemic, COVID-19, just changed our world in ways that I think we're still processing. We didn't quite know. As I watched the news, as we all watched the news, one thing that really resonated with me were there were certain organizations that seemed to be a bit more resilient. They almost seemed to be a bit more prepared for what they were doing. One was right here in my backyard, the Cleveland Clinic. So there was a special call for papers. I reached out to a few colleagues, and we really sought out to talk to a few folks at the Cleveland Clinic and figure out what did they do? What made it unique for him? So, we all know in the later months of 2019, the pandemic began. It basically started over in Europe, other places in the world, and we all saw it in the news. It had unprecedented challenges for healthcare systems. They were dealing with things that they really had never quite dealt with before. Unprecedented volumes of patients, needs for beds, supplies, caregiver issues. In some of the research we found, there were anticipated losses of $323 billion in 2020, just in US healthcare systems alone. At that time, 270 hospitals and systems, and when I say systems, it's things like the Cleveland Clinic, it's a group of hospitals. They had mandatory furloughs. I mean, they were all struggling really to deal with this potential loss. They had layoffs. They cut pay for clinical staff, and doing so, they further limited the care that was available to the COVID patients that were coming in droves. In fact, I actually saw on Becker's Hospital Review today that 8 large systems have continued to lay providers off. So this has not stopped. They're still struggling with really how to keep afloat. So we took the opportunity, we spoke to Dr. Mark Taylor. He is a chair of surgical operations for the Cleveland Clinic. And we really try to get his feeling, in addition to looking at some of the resources that were out there, some of the statistics that were out there already, to figure out what did the clinic do? What made it work? What made it unique? So one of the main things that he talked about was first engaging the key stakeholders. So really, who are the people in charge? Who are the people that can make things happen? They started proactively watching what was going on in Europe. And they realized that's probably coming here. And it's something we need to get ready for. So one of the first things they did is they set up an incident command center, which was really their central hub of information. And the information and the way in which they handle information is really key to their success. So they had system-wide groups where they focused on things like communication, collaboration. In addition, they had subgroups that were more localized issues. Some of their ancillary hospitals, some of the small regional hospitals, and perhaps even elsewhere in the world, because some of the problems were very unique. Then they looked at things like physical space. Where do we put our patients? We're at bed capacity. Now, I'm going to let Dr. Stoller talk a bit more about that when he presents, because I'm certainly looking from the outside perspective of Cleveland Clinic. He was living it on a day-to-day basis, so he can kind of give us a little insight there. They did some really interesting things, in my opinion. One, they deployed their workers. So a lot of the other hospital systems, because they weren't doing same-day surgery, perhaps they weren't doing some of the testing that they do routinely, they said, we basically have to put a hold on certain things, and we're going to lay those people off. We're going to, lay them off, downsize them, furlough them, whatever it might be, and we'll save that money. The clinic, however, realized that even though somebody is perhaps, a surgeon, they've got the basic skills certainly to handle patients. So they redeployed them. They sent people elsewhere. So they were right there on the front lines. Now, there are certain little challenges associated with that, which I'm sure Dr. Stoller will talk about also, but they needed to establish some new protocols and even some training. There might have been equipment or things that, because their discipline was a little bit different, they weren't necessarily used to. Now, we all read about the equipment challenges. And if you watch the news on a daily basis, you saw hoarding that was going on. People were hoarding equipment. They were buying it off of Amazon. They were desperate. They were desperate to make sure that these clinicians, when they went to work, that they were protecting themselves, that they were protecting their families. They were terrified that they wouldn't have PPE, that there weren't be enough ventilators. The clinic, however, set up online dashboards that were real time that basically said, here is exactly what we have, and here's exactly where it's located. And that seemed to really mitigate the fear, the hoarding, the fact that people would go elsewhere to get things because they were able to look at that and trust that the clinic was looking out for them, and they had the equipment necessary to do their job on a daily basis, and they knew where to go and get it. So that was huge. They also had, which I thought was really interesting, their communication strategy. They had these organization-wide webinars that were obviously huge, huge. But the neat thing was anybody could get on them, anyone. And granted, they were large, so they would share information, they would have challenges, they would brainstorm their way through things. We tried this here, that sort of thing. And they would also try to clarify misinformation. But it was very important to them that everyone in the Cleveland Clinic, regardless of level, was welcome, that they had an opportunity to voice their concerns, they had an opportunity to share their questions, and they would be treated as anyone else there. This was just their idea. Full transparency at the clinic is huge, very important. And I think it's very unique. So, really, why was the Cleveland Clinic successful, in my opinion? A couple of things. First, they were built on full transparency. And as I said before, regardless of employee stature. So anybody, and they really, really wanted to make sure that people understood what was going on, even if it was, difficult or challenging information. With that built trust. So obviously the people could trust the information. They didn't feel like it was being misled or, hidden in any way. And as we all know, working in organizations, if people don't feel that things are being transparent, if they cannot trust the information they're going to be given, they'll fill it in. And they'll fill it in what I often call almost adult telephone, where, they will fill it in with things that maybe just don't make a lot of sense because they have a need to understand and they have a need to know. So that trust at all levels, once again, was built on information. It made them feel like they weren't going to lose their jobs. It made them feel like the clinic was concerned about their personal well-being and making sure that they were personally safe. The redeployment, in addition to avoiding layoffs, furloughs, pay cuts, and things like that for the clinicians, it also offered them additional training. And, training to the Cleveland Clinic is paramount. Everyone is learning all the time. They never get to a point where they feel like, they know what they're doing necessarily and cannot learn more. And the other thing it did is it prepared them, because unfortunately, what many of us have heard is there are going to be future pandemics. So, it prepared them and they learned from that particular situation. So the one thing that I would leave you all with is think about what can your organization do proactively to really develop, what we sort of coined as a one team approach in our paper. So the Cleveland Clinic doesn't work as a subsection of teams all over the world. They really attempt to focus as one team. Standardization of information, standardization of transparency, building trust across the board. So, that really is the unique situation. So at this point, I'm going to turn it over to Dr. Stoller, and he's going to share the inside perspective on really what they dealt with. So Dr. Stoller, and I will unshare my screen. Bear with me for a moment.
Thank you, Dr. Porter. It's a privilege to join you all today. I will share my screen as I pivot to discussing this. They say lung doctors are long-winded about the short-winded, and I'll try to belie that reputation. I plan to really reflect on the themes that Tracy has so nicely teed up, and try to embed this in the concept of organizational culture. So the idea of, and this image on your bottom right, the idea of leading forward by looking backward, and embedded principles in the culture of the organization. I'll be really discussing this intersection of organizational culture, leadership, and performance in my brief remarks. So in the context that a crisis is a terrible thing to waste, Paul Romer's comments from some years ago, Nobel Prize laureate in economics, the clinic has really embraced the idea, and actually have most healthcare organizations, that a crisis is a terrible thing to waste. And so what learning opportunities are there? I'll be talking about organizational culture. I'll pivot to virtue-based culture. I'll say a word about our history, because the culture is deeply embedded in our 100-year history. Talk briefly about the impact of COVID-19, and then tell you a story about our response in a somewhat more granular way to the surge of hospital beds and the inadequate supply of ventilators, requiring something called multiplex ventilation, the ability to care for more than one patient with one machine. And then I'll reflect on some leadership principles. This quote from Peter Drucker, well-known organizational guru, well-known: culture eats strategy for lunch. And of course, what is culture? This is the classic work of Cotter and Heskett. It's behavior patterns or style that employees are automatically encouraged to follow. Its culture develops when a group of employees interact over a period of time with solutions that repeatedly solve the problems. And in a more granular way, this is what culture is. It's how things are done around here. And the clinic, having been on the staff at the clinic for now 35 years, has a deep organizational culture. Does it matter? Yes. Again, Cotter and Heskett's work, one small snapshot: organizations with strong cultures perform financially better than those that have less enhancing cultures, as you can see in the right column. Now, these are financial metrics. I'll be telling you stories about healthcare success as a function of culture. And as Dr. Khan alluded, my vision around culture is often embedded in the classic Aristotelian virtues of trust, compassion, courage, justice, wisdom, temperance, and hope. These are virtues that help us navigate what the military has called a VUCA world, a world that's volatile, uncertain, complex, and ambiguous. And by all means, the pandemic surfaced VUCA characteristics, I think we could all say. And so the notion is, and I'll try to build the case, that when leaders develop cultures that are based on meaningful and trusting relationships, when there's trust and compassion in the organization as foundational virtue-based principles, you unleash the discretionary effort in the organization. It's not a carrot and stick environment. When you get better at who you are, when you create a virtue-based culture, you get better at what you do, performance is enhanced. So with that sort of as a backdrop, let me pivot to our history. The clinic, now celebrating its 100th year, was founded by 4 docs, Frank Bunce, George Kreil Sr., William Lauer, and John Phillips, the first internist, who were practicing in Cleveland in the late teens, a century ago, went off to World War I in France and were deployed together in a military hospital, and realized in that model that there was a new model of medicine, a model framed by the concept quite active today, our mantra at the clinic of acting as a unit. This is Dr. Porter's one team approach. And the vision that they articulated was our tripartite mission, recently modernized for our 100th anniversary, of caring for life, our clinical mission, researching for health, and our educational mission, educating those who serve. And so if we were to try to provide an infographic of our culture, that we have 4 priorities that Tom Mihaljevic, our CEO, consistently articulates: our care and commitment to patients, our care for each other as caregivers, our care for the community, and our care for the organization. So treat your colleagues as though they're family members, and the organization as though it's your home. And in the middle, our values, which are very much tied to the Aristotelian virtues that I've shown you below. The idea of integrity as a foundational principle, and commitments to quality and safety, to empathy, to teamwork, to innovation, and to inclusion. So let me pivot to COVID. I think you all have felt this, as we have as healthcare providers. As of yesterday, the tragedy of COVID, not yet gone by any means, is that there are 159 million cases worldwide and 3 million deaths. In the United States, 33 million cases, 595,000 deaths. And this created, as Dr. Porter has nicely summarized, a perfect storm for healthcare. And let me unpack that slightly. First of all, there was incredible system stress, and I'll get a little bit more granular about the threat on bed capacity, the threat on equipment. Thankfully, we had ample PPE at the clinic, thanks to superb planning from our colleagues in facilities and operations. But no one had enough ventilators, no one had enough beds, and I'll show you the models that very early on articulated that. There was incredible financial stress, as Tracy has nicely articulated. This was related both to the expenditures around COVID, as well as the decline in discretionary visits. Elective surgeries were canceled. There were huge budgetary shortfalls, somewhat shored up by the government and the CARES Act, but certainly incompletely. And health systems actually went under. There was incredible caregiver stress. You know, doctors are used to knowing what they're doing. This was a brand new disease for which there was really no empiric experience. We were uncovering a new problem, which was severe. There was lots of death and dying. We were all working, even as pulmonary critical care doctors, working outside of our scope of practice, but colleagues not used to caring for patients with lung disease, surgeons, dermatologists, orthopedic surgeons, et cetera, were, as Dr. Porter mentioned, redeployed. And there was an upskilling requirement. And I'll share with you the impact and magnitude of that. There was also the issue of personal risk. And thankfully, not at the clinic, but in other organizations, inadequate PPE. We see this in India now. So some early models, my colleagues, Jim Simon and colleagues with our business intelligence group, which was a long-standing group, actually developed from many years ago, but also deployed in the era of Ebola, which thankfully never materialized to a pandemic in the United States, but which was deployed when Ebola became an issue. And so we had these capabilities at baseline. And colleagues started to model as a function of social distancing. You can see blue, 0 social distancing, light yellow, 20%, et cetera, what the bed requirements would be. And this is March of 2020. The WHO declared it a pandemic on March 11th. And so these models were prepared almost immediately. And you can see that under assumptions about varying degrees of social distancing, the worst case scenario was that there was a need for about 8,000 beds in Northeast Ohio, which far exceeds the total bed capacity of the institution. Similarly, looking at patients needing mechanical ventilation, patients whose lungs fail and therefore need ventilatory assistance with a machine that helps inflate their lungs and provides oxygen, gets rid of carbon dioxide. That's what lungs do under normal circumstances. And when they fail, that's what machines help them do. We have a very ample supply of 357 ventilators at the Cleveland Clinic, but you can see that these models predicted the need for potentially up to 1,600 ventilators. And these couldn't be manufactured or deployed from other places in the United States quickly enough. So there was a need for a novel, innovative solution about how to care for many thousands of patients with 357 machines. And so this invites the whole discussion of leadership. And again, the comment about leading forward by looking backwards, both at the virtues and some age-old wisdom. Now, Gallup data show us that there are 4 components of effective leadership. 3 of them, shown here in yellow, are in fact virtues: trust, compassion, and hope. When leaders create environments with these underlying values, they are leading effectively. Stability is another component. And so scroll back to March 2020. WHO declares a pandemic on March 11th. Tom Mihaljevic, at a time when the Cleveland Clinic, like all healthcare organizations, were challenged financially, makes a declaration in concert with our value of caring for caregivers, one of the 4 cares: caring for caregivers, caring for the community, caring for our patients, and caring for the organization, that we are a team and we will navigate the pandemic as a team. This was a declaration in the face of tremendous financial shortfalls, again, related to canceling elective surgery, expenditures for COVID, for PPE, et cetera. And he made the commitment when many other organizations were not doing this, including some in our immediate environment, that every caregiver will be kept whole. There will be no layoffs, no furloughs. And this, of course, this declaration affirmed stability in the face of a very trying interval. The result of which, as you can see in these data, looking at a Press-Ganey survey of 41,000 Cleveland Clinic caregivers, a reasonably representative sample, there were upticks of ratings that were already very high in 2017, 2019. We periodically survey the organization, but you can see substantial upticks about executive leadership providing open and honest communication. I would stay with the clinic, and I would recommend the clinic as a good place to work. Our retention is extraordinarily high. In the face of 1-year appointments and no tenure, the turnover on the faculty, on the staff, is about 5% per year, which is largely related to outmigration for leadership roles that are available elsewhere. And so finally, let me pivot to a brief conversation on performance. And so in my own reflections on this, published in BMJ Leader now a year ago, there were some components that quite nicely overlap with Mark Taylor's reflections and Dr. Porter's paper. The idea of proactivity, of anticipating events by modeling events and using models and contingency plans. This really speaks to Ben Franklin's notion that if you fail to plan, you're planning to fail. Some age-old wisdom, looking backwards to go forward. And so we needed to urgently address the bed capacity and the need for more ventilators, as well as the need to upskill colleagues whose usual scope of practice is not taking care of patients with lung failure or in the ICU. Now I'll pivot up to 93rd and Chester. Many of you in Cleveland are aware of this marvelous building recently constructed, our health education campus, which is the site for the Cleveland Clinic Lerner College of Medicine, the Case Western Reserve University School of Medicine, the School of Dental Medicine, the School of Nursing, a novel, innovative collaboration between Case Western Reserve and the Cleveland Clinic, which was designed elegantly by Foster and Partners. It's a huge space, 477,000 square feet. You may also remember this from the site of one of the presidential debates. And this space, which is an educational space shown on your left, in the course of 28 days was converted to a surge hospital with 1,066 bed capacity. This is not a trivial undertaking. It requires bringing in supplemental oxygen, bringing in suction to care for patients in each of these bed spaces shown to your right. This was done in incredible nimbleness in the course of 28 days with teams that were deployed very nimbly, tradesmen working 24/7 with incredible metrics of by the numbers, 6 miles of medical grade copper tubing to bring in supplemental oxygen that when used would inflate two and a half hot air balloons daily. Imagine the volume of oxygen being used. 13 miles of extension cords, et cetera. Thankfully, the space was never actually used, although it was completely built as a hospital to accommodate 1,000 patients. The second was really a quintessential example of medical innovation and collaboration. And so shown here on the top is one of my partners, Umar Hatipolu, and one of my colleagues, Rob Chatburn, who together figured out a very vexing physiologic problem of how to use one ventilator, shown on the top, on more than one patient, which, without getting too granular, is a very challenging physiologic problem that has actually not, until now, ever been solved. And so in collaborating with colleagues at Parker Hannifin, Dale Ashby and his team, with rapid prototyping, this team developed a workable multiplex ventilator in which one ventilator could care for 2 patients, therefore doubling our ventilator capacity, thankfully never deployed, but fully ready to go. And so we also needed to upskill caregivers, as Dr. Porter mentioned, training dermatologists to care for inpatients, training orthopedic surgeons to care for patients in the ICU, requiring education and the deployment of teams. And so modules were developed, placed online, and as of today, there were 43 such courses that were observed in 813,193 page views by 65,000 caregivers at the Cleveland Clinic. And then in our spirit of altruism, we of course made these available to the world with outward-facing portals that have been viewed 157,528 page views by 56,000 individuals in 152 countries around the world. The upskilling also involved publishing our work in the Cleveland Clinic Journal of Medicine, 94 such curbside consults, we call them, with 500,000 page views. So the other principles were clarifying governance for the crisis, a single source of truth, models. We had a pre-existing incident command center that had been mobilized from Ebola, regular leadership meetings and rapid deployment, the idea of acting quickly, the idea of acknowledging fallibility. I remember very, very well Tom Mihaljevic standing up virtually, of course, and telling us that we're going to make mistakes. We're going to do it together. We're going to kill bad ideas fast. We're going to create psychological safety. And each of us as leaders deployed and cascaded that awareness through our own institutes. It gets to Voltaire's quote, "Don't make perfect the enemy of good." There was a sense of both realism, that this is a grave crisis, as well as optimism. And so leaders uniformly acknowledged the challenge, but still modeled optimism. They rewarded and recognized colleagues that were doing incredible work. Storytelling, stories inspire and facts convince. And the institution was full of stories about people going beyond. This would harness the discretionary effort of the organization, not a carrot and stick approach, but an organic pulling together, working in the context of our culture of acting as a unit, bringing forward incredible performance. This is F. Scott Fitzgerald's quote, "The test of a first-rate intelligence is the ability to hold 2 opposed ideas in the mind at the same time and still retain the ability to function, acknowledging challenge and modeling optimism." And Churchill, acknowledging that a pessimist sees every difficulty and every opportunity, and an optimist sees every opportunity and every difficulty. And we clearly pivoted to the optimistic lens and the idea, if you're going through hell, just keep going. And so this was a daily mantra within the organization. And finally, the idea of frequent and forthright communication. Again, embedded with the idea of admitting fallibility and making mistakes and pivoting. Now, all of which affirmed the culture, again, acting as a unit and paying attention to our 4 cares: patients, caregivers, community, and the organization. Reminding us of George Bernard Shaw's quote that the single biggest problem is in communication is the illusion it's occurred. So my key takeaways are several. That organizational culture and leadership are key drivers of organizational performance, and our ability to act as a unit, which is deeply embedded in the culture of the organization, has positioned us really well for performance in the face of a crisis. That leadership requires pre-occurrence planning and rapid execution of plans. And that prior attention to building a healthy organizational culture and acting in concert with that culture around the principles that Dr. Porter has so nicely articulated: transparency, psychological safety, Amy Edmondson's concepts, admission of fallibility, are critical success elements. And again, time-honored wisdom, the idea of leading forward by looking backwards, attention to the 7 classical virtues, and to wisdom that's well preceded the pandemic, that will again position us for pandemics to come. So with that, we've left time for questions. I think we all invite your dialogue and look forward to the dialogue that follows. So thank you very much. Stop sharing my screen.
So at this point, let's open it up for questions for our speakers, and feel free to either type your question in the chat function, and we also have a Q&A function as well in this Zoom webinar setup. So you have two locations for submitting questions, either through the chat or for the Q&A. With that, why don't we start off, have one question that we can start with. Based on your opinion, how has the pandemic changed companies' approaches to making resilience happen? And how has the pandemic possibly changed companies' approaches for managing and leading through crises?
Tracy, do you want to take a stab, or shall I?
Okay, well, I'll jump in. I think, anecdotally, I think a lot of organizations, it's made them think. It's given them a time to pause and think about what do they need to do, and really the takeaways of what worked and how can they. And I think that's the purpose of this particular webinar, is how can we learn from each other. And Dr. Stoller pointed out, they're very much of a learning organization. They allow themselves to come up with ideas. They allow themselves to be wrong. But they allow themselves to question, because we're just dealing with an unprecedented time. So I think that is, in my opinion, what it's done for organizations. It's caused them to stop and think about what worked, what didn't.
I think the other thing I would add is that the pandemic has actually given us confidence, because we've been tested in a real world sense. And although we're not done with this, I think there's a sense of organizational confidence that follows our performance that was always present, but I would say has been exaggerated in the face of recent performance. And so what we tell the medical students and our trainees who have trained and are learning medicine in an unprecedented time is that they're unusually positioned to navigate the challenges of a trying career, because of the experience they've had of pivoting to virtual learning, of pivoting to innovative practices that there was no playbook, there are no guidebooks for this, and yet we've navigated it well. So I think I would emphasize what Dr. Porter said about the importance of a learning organization and the idea of resilience through confidence in performance.
Thank you. We actually have some questions coming in. One is a little more specific, but I didn't know if you might want to comment. It pertains to the ship in New York City. And the question is, why was there no need for the emergency center that was set up in record time? And this pertains to the New York City ship. Any thoughts, comments?
Well, I think this was a generalizable theme, thankfully. As I said, we built a 1,066 bed Hope Hospital and never had a single patient in it. I think the same thing was largely true. It's my impression that there were a few patients cared for in Central Park in New York, and maybe a couple on the Hope ship that was deployed to New York, but certainly not used to the capacity that it represented. And I think that simply reinforced the fact that we were pivoting in real time, that we were improvising and doing multiple things at once, canceling elective surgeries, redeploying beds, making new ICUs within the hospital, that ultimately preempted the need to use these ancillary bed capacity, although it was obviously, as you can see from the early models, very important to have that. That provided organizational confidence and our ability to function in the face of very trying day-to-day challenges. So hopefully that's responsive to that excellent question.
Dr. Porter, any comments?
Well, I think, there might be some that say it was a lot of time, it was a lot of effort, and it wasn't necessarily needed. However, we hope that that's the case. We hope that they aren't needed. So we were proactive. And as Dr. Stoller has noted, we've learned from every step. We've learned by bringing in the Hope ship to New York that fortunately was not needed. The Cleveland Clinic learned by very, very quickly setting up this hospital that we hope is not going to be needed in the future. But if and when it might be, they have learned from that process and probably could do so even at less time than 28 days. So I think it's important for us to still be very proactive and then, learn from each process.
We have another question. We actually have a number coming in. So question, how has the pandemic changed the healthcare environment as it relates to collaboration versus competition? Were there any lessons learned on collaborating with another institution, such as the university hospitals, during the pandemic?
Yes, emphatically yes. Cleveland enjoys a fabulous healthcare scene, which, although it may be invisible to the lay public, actually is predicated on incredible interinstitutional collaboration. And while there is, of course, competition, and you may see that in advertisements and so on, in fact, underneath all of that, there's far more collaboration than not. And so if we think of, for example, university collaborations, we collaborate with Case Western Reserve University in a common medical school, in a comprehensive cancer center, in our center for, in our CTSA, which is a research machine. We collaborate with Cleveland State. We collectively offer a master's in health education with colleagues in the School of Education at CSU. So there are these underpinnings of deep collaborations within the city. In the face of a crisis, many of you saw the CEOs of the multiple organizations of Metro, UH, and the clinic come together and commit to vaccination and early on testing strategies that were collaboratively shared with no attention to cost. There was no cost accounting in these undertakings at tremendous cost to the organizations, by the way. So this was the ultimate collaboration in service of mission. All of the healthcare organizations, both in Cleveland and everywhere, I've trained in organizations in Boston and Connecticut and around the world. All of them are committed to taking care of patients first. And these real collaborations were demonstrations of the authenticity of mission around that. So there were very clear collaborations that were wonderfully laid bare by the pandemic.
All right. Now, if I might add to that, I mean, Dr. Stoller had noted the training modules that were set up to get the providers up to speed. You shared that right away. And I think that's another just a point that is important to the Cleveland Clinic culture. But I think to your point, it is important to other healthcare organizations. And they've got to, especially in the face of something like a pandemic, they've got to work collaboratively. They've got to build trust amongst each other because they each have their own areas of strength that they can build upon. So
it's a fabulous question.
Somewhat related, have another question. How did the clinic coordinate with the Ohio Department of Health and with other providers in Ohio?
Yeah, there's a hotline between the clinic and the governor's office. And so Bob Wiley, one of my colleagues who helps run operations, clinical operations at the clinic, has been on the governor's task force from very early on. This was a carryover from Ebola, in fact, although that was much less in the news because it was much less of an immediate threat to the health of Americans, was nonetheless had a similar signal in Africa that was in some ways even more lethal than COVID, potentially more lethal. And so based on that experience from, of course, we have flu epidemics every year, right? Every year between November and May, there's a proliferation of influenza. Again, strongly advise everyone to get their flu shot, as I do their COVID vaccination, because that mollifies the risk. But based on all of these perennial challenges, the clinic has a long-standing interaction with the governor's office. Actually, our CEOs were talking with the president. Actually, we're speaking from podia with Tony Fauci and other leaders that you see on the news every day. And so these are pre-existing communication channels that, again, were deployed in the face of a crisis, but pre-existed. Yeah.
Anything you want to add?
No, I don't think, I think Dr. Stoller is best positioned to answer that question.
So another question pertaining to the clinic that we have, given what you've found, what worked for the clinic, what lessons were learned that could help convince skeptics to accept the pandemic and get vaccinated?
Well, I think that what we've all learned in this country and the world is absolute faith in the scientific process. You've all heard this on the news. I dare say I won't say anything novel, but the idea of the world coming together to develop a vaccine in 9 months' time that had 95% efficacy is unprecedented in the history of the universe. The prior world's record in developing a vaccine, not an mRNA vaccine, this was novel technology, by the way, was the mumps vaccine, which is highly effective and took 4 years to develop. And there's been work on vaccines for HIV and tuberculosis that have yet to bear fruit, complete fruit. And so the notion that we actually have a vaccine is an absolute affirmation of the rigor and dependability of the scientific process. And naysayers may say, well, there's the occasional side effect. You know, there is absolutely the occasional side effect, but on balance, in terms of a risk-benefit ratio, it is absolutely incontrovertibly clear that these vaccines have efficacy and should be universally accepted. You know, in the rare instance of an anaphylactic reaction, there are always asterisks, but that affects a tiny, tiny, tiny minority of the world's population. So lessons here are age-old lessons, again, leading forward by looking backwards. Science works, and the clinic and every other academic healthcare organization invests incredible amounts of intellectual power, financial resources in advancing our research mission and then disseminating awareness of that mission through education. This is a model that works. And so my confidence in the scientific community is again bolstered by our experience. This is great news for us. You should only ask your doctors as to whether they're going to roll up their sleeves. There's not a single individual I know who knows anything about this that wasn't wanting to be first in line to get a vaccine. I'm fully vaccinated, and I'm delighted to tell you that I have been.
I would totally agree. I too am fully vaccinated. I was there as quickly as they would allow me in the door. And I agree with you. I think in particular in the United States, the scientific process is something that, and myself as a social scientist, is near and dear to who we are as professionals. And I think in the United States, we don't cut corners. We really, you know, it's amazing what we can do when we come together. I mean, really, if you sit back and think about that, it was a brand new disease. And in less than a year, we came out with 1, 2, 3 vaccines that have an efficacy of over 90%. It's incredible. We should be unbelievably proud of that and build on that for the future.
And this actually is a nice follow-up. Ohio is around 40% vaccination rate for at least one vaccine. What ideas, strategies can private and public organizations deploy to raise that rate to be closer to herd immunity?
Yeah, I think we see this now. And so, you know, as I watch, this has been an evolution of the process. When there was scarcity of vaccine, it was deployed really through centralized resources. And as supply became more liberal, more vaccines coming online, more manufacturing, then we had these mega sites like the Wolstein Center, right, in which Cleveland State played a hugely important role in disseminating vaccine to the population of Cleveland and Ohio in general. And now, of course, I was watching the news on the elliptical this morning, and I saw that there was an advertisement for a furniture company that said that if you came in to get to look at furniture, you'd get a vaccine in the store. So now vaccine is being brought to the populace. I have colleagues at the clinic who go to people's homes and administer vaccine, or go to nursing homes. And so there is this taking the vaccine to the people as opposed to expecting the people will come to the vaccine. And by making this more geographically dispersible and more organically available, I think we're really addressing availability. Now, the thing that is concerning is that the uptake rate still continues to slacken as availability is increased. And there is, of course, hesitancy and skepticism is certainly understandable. But I would again encourage everyone, given the faith in science, to take advantage of this. This can save your life. This can save your life. I can tell you, as someone who's cared for these patients, this is a scary, unpredictable disease. You do not want to get it. We're better off meeting here than where I work. Let me assure you.
All right. Well said. One of the reasons that we had the mass vaccination clinic at the Cleveland Clinic at Cleveland State was because we're located in the central neighborhood. So we wanted it to be readily available to people that first might be hesitant to go there, but second, make it available to them. And as a person that went there to get my vaccine, I was blown away by the quality, by the professionalism of everybody that worked there. I mean, it made me exceedingly proud to be an employee of Cleveland State, I will say that. I also understand that there are people that are hesitant. I would encourage people to educate themselves appropriately through resources such as the Cleveland Clinic website or, the CDC website, to educate themselves with valid information and not necessarily anywhere. You can't just Google it or just listen to anecdotal information. I think we have to know, what is science saying, and what has been proven so far, and then make their decision.
Have a question about the respirator and the ventilator concept that you shared. And the question is, how did the Cleveland Clinic get introduced to Parker Hanif?
So we've had a longstanding association with Parker Hanif in many dimensions, usually around technology and innovation. I can speak to that personally. The book that we wrote was co-authored with a colleague, Peter Ray, who's a senior executive at Parker Hanif, and was the dean at BW and the business school for many years. And so the tentacles between large organizations in Cleveland, whether it's technology and healthcare, business and healthcare, education and healthcare, these tentacles have pre-existed for many years. And they came to the fore in the face of crises that bring out the best. Again, these collaborations between Dale Ashby's team and my colleagues who developed the multiplex ventilator, they happened organically in the moment. Teams deployed, again, no attention to cost, the prototyping. These prototypes are expensive, and they went through multiple iterations to get these valves and flow sensors correct. Again, can't be done solely by a healthcare organization, requires collaboration. But these tentacles well pre-existed and were mobilized in the face of crisis.
And a related follow-up is, has the dual patient ventilator technology been shared with other countries?
Absolutely. The data were published. I showed you on the bottom of that slide the publication that described the complete technology. One of the things we're very good at in academic medicine is there's an early appetite to share wisdom rather than to hoard wisdom in service of patents or any of that sort. There was no attention to that whatsoever. These ideas were promulgated widely and made available, and I'm sure there were email exchanges across the world. Tell us, how do you fix this valve and how do you do that, and so on. So these were graciously and enthusiastically shared.
So I have a question here, a little bit of change of gears. How have each of you managed your own mental health during the pandemic? And there was a follow-up about concerns with vaccination rates declining, but I think let's focus in on that first part. How is the clinic also looking at the issue of mental health?
I could take a stab and then I invite Tracy. So first personally and then organizationally. I have always been a fit person and committed to exercise. I've run a number of marathons and so on. And my personal response to the pandemic was to double down on exercise. So I literally get up quite early. I'm on the elliptical an hour and a half a day. The only day I missed was one day when I was a little bit under the weather. feeling a little bit sore after my second vaccine. Not a reason not to do it, by the way, a good sore, as I say. And the other thing that I've done is to sort of reflect by writing. And so the paper I shared, which was the nidus of some of my comments, was my attempting to process this by putting finger to keypad and seeking clarity in my thoughts by writing it down and then sharing that. At an organizational level, there's a huge investment in mental health, and our colleagues Leo Pozuelo, Don Malone, who chairs our Department of Psychiatry, are constantly in conversation with the organization about it's okay to not feel okay, to giving permission to people not to be macho about this, but to come forward with the issues that are on everyone's mind. All of us have been stressed by this, without a doubt. There's not a single individual in the world. Some have experienced incredible loss, but all of us have experienced loss in one way or another, and we're in it together. So normalizing that and creating psychological safety around it have been incredibly important, both personally and organizationally.
From a healthcare perspective, even prior to COVID, physician burnout, clinical burnout was a huge issue because doctors are being asked to do more and more. Often, sometimes depending on where they're working, with less and less resources. So I think we're just starting to look at what is going to be the impact of this particular pandemic on our clinical staff. And I think it's something we do need to pay attention to. And I think it's wonderful that the clinic is very open about that and they embrace that. I will say from a personal perspective, Cleveland State also tried to do the same because we were all quickly moving online, trying desperately to support our students, trying to do our best, feeling like we weren't necessarily doing things the way that we should. So it really has been a difficult year, but I think allowing that space to reflect and to realize that we're doing our best, we're learning as we're going along. We will make mistakes, as I have made mistakes in classes. We will get better. And then when we come out on the other side, we'll think about what sort of things do we want to continue? You know, what has worked, what has supported my students in a way that maybe I didn't before, you know, what sort of things. I am a big believer in going to the gym every day, not for an hour and a half. I do commend you on that. But I think taking space and time for ourselves is very important also.
We have a question about hospital systems. And the question is, how do you imagine hospital systems will balance the future equations of expansion? And basically related to how is the pandemic going to change how hospitals be looking at expansion? And I'm just paraphrasing the question. One of the issues is, as they're looking at future expansions, how is the issue of speed for rapidly converting space part of that equation? How is the issue of social distance going to come into that equation? So I paraphrased it, but how do you look at the directions for hospital expansion?
Yeah, it's a fascinating question. All of these have been fabulous questions. I think one of the other learnings, the clinic is ever expanding. We currently have, I think, 12 hospitals around Northeast Ohio, as well as hospitals in Las Vegas and Abu Dhabi and London and Canada, and of course in Florida. And one of the learnings for us has been cascading awareness throughout the entire hospital system. So the protocols that were developed in the ICUs here in the main campus were shared broadly in London, Abu Dhabi, and abided by, with uniformly excellent outcomes in the ICU and in the hospital. So the idea of driving systemness through sharing and having conjoint knowledge has become yet more important. And I think will be a driver of the consolidation in healthcare that you started to see actually pre-existing the pandemic, but probably exaggerated by the pandemic, not only by the financial instability of some systems related to the financial pressures of the pandemic, but also by the opportunities that come with aggregating talent and aggregating systems and the efficiencies of scale that we've appreciated at a large healthcare organization like the Cleveland Clinic. It's challenged by social distancing, that, you know, space is the final frontier in every organization. And when we've had to limit space, that will improve over time, I expect, as herd immunity is achieved. We will get back to normal interaction. So that's a transient problem, but the consolidation is a long-standing solution. I'll stop there.
All right. I think systemness, I think to your point, is only going to increase. I know something that's very important to the Cleveland Clinic as they acquire a new hospital or they build a new hospital and bring in staff to infuse the Cleveland Clinic DNA is the way that it's been referred to me into that particular organization. I think you're going to see a lot of smaller hospitals in particular now being bought up by a system. One of the main reasons is cost. They can certainly spread costs. But we don't want to also lose our smaller community hospitals that are sometimes unbelievably important to the smaller neighborhoods they might be located within. So I think systemness they're only going to expand. And I think we have to carefully think about what should that look like and what should that mean?
Well, I'd like to thank both of you. We actually have reached our time limit, and I get to serve in the role of time cop. But I'd like to thank both of you for joining us, now we can say officially this afternoon, and sharing your thoughts. So thank you very much. And so if everyone can join me, thank you very much for your time and for speaking on the topic.
Total pleasure.
I'd like to thank all of you that are listening for joining us as well for this third part of our three-part Cornerstone speaker series. We will continue the speaker series in the fall and also into the spring, with each having their own three-part series. We will be returning. The plan right now, we have a committee looking at the themes and speakers for this fall, but we'll be looking at how the pandemic is affecting work and looking at hybrid work models. We are planning to have and use a third Thursday model, with our planned dates being September 16th, October 21st, and November 18th, hoping you can join us. So on behalf of the Monte Ahuja College of Business, thank you again for joining us, and everybody have a very good rest of your day and a very safe and enjoyable summer. Thanks so much for joining us. Take care.
Thank you very much.
Okay.